Welcome to Nephroapp's Clinical Cases Uncovered. It's where we try to sort out all the crazy renal puzzles.
Yeah, it's like giving your nephrology brain a workout.
Exactly.
Yeah.
And today on the show, we've got a real head-scratcher. It's the case of the vanishing urine.
Sounds intriguing.
So our patient is an 84-year-old gentleman, Mr. Godfrey Griffiths. He came in with shortness of breath.
Not unusual for an 84-year-old.
Right, but initially he got better, but then things took a turn for the worse, and he started having this like crazy diarrhea and vomiting.
Oh, not good.
Yeah, and on top of that, his urine output just like plummeted.
So the kidneys are joining the party.
It really makes you wonder, is this, just a simple dehydration, or is there something more serious going on with his kidneys?
Well, before we jump in the deep end with, creatinine and all that jazz, we got to make sure we've covered the basics, ABCs first.
Always a good reminder. So his oxygen saturation was actually pretty good, 98% on room air. His respiratory rate was a bit fast at 22.
Okay.
Pulse was 100 and regular, and his blood pressure was 105/55.
All right, so stable enough to proceed. Let's dig into this case.
Okay, so the nurses were, understandably freaking out about his urine output because it was only 70 milliliters in 6 hours.
Wow, that's pretty low.
And to make things even trickier, his diarrhea losses were like completely unmeasurable.
So fluid balance calculations were pretty much out the window.
Exactly. It was like trying to solve a math problem with missing numbers.
I hate when that happens.
So let's rewind a bit and look at Mr. Griffith's past medical history. What do we know about him?
Well, he had a myocardial infarction about 5 years ago, and he's got a history of left ventricular dysfunction,
Okay.
type 2 diabetes, which he's managing with diet and metformin.
Interesting.
Oh, and he's a lifelong smoker, which is never good news.
And what about his prostate?
He did mention having a weak urinary stream, but there's no documented history of prostate problems.
Okay, so we were examining him, and it was like this mental tug of war. On the one hand, he was clearly dehydrated.
Right.
But on the other hand, he's got this history of pulmonary edema.
Yeah, so giving fluids is a bit of a tightrope walk.
Absolutely.
Yeah.
So tell me, what did you find on his physical exam?
Well, he definitely looked dehydrated, dry mucous membranes, reduced skin turgor.
Uh-huh.
He had a fever of 38 degrees Celsius, tachycardia, hypotension, with a postural drop of 15 millimol of G systolic.
Wow, the hits keep coming.
And to top it all off, he even had a pansystolic murmur.
Oh boy, this guy's a walking textbook case.
His abdomen was a bit tender, but luckily no signs of peritonitis.
Okay, well that's good, Lisa. So what did the labs show?
All right, so his white blood cell count was elevated at 12 times 10 to the 9th per liter. Hemoglobin was slightly high at 160 grams per liter.
Okay.
But the real shocker was his creatinine. It had skyrocketed to 520 micromoles per liter compared to 185 on admission.
Whoa, that's a massive jump.
And CRP was also elevated at 60 milligrams per liter.
Okay, so inflammation is definitely part of the picture. What about imaging?
His chest x-ray showed mild cardiomegaly and some signs of COPD, which wasn't surprising given his smoking history. But the renal ultrasound was a bit unexpected. His kidneys were measuring only 9 centimeters bilaterally.
That's small.
And there was no sign of obstruction.
Okay, so we've got all these pieces of the puzzle now. What's your take on what's causing Mr. Griffith's acute kidney injury?
Well, the small kidneys and that initial elevated creatinine definitely point towards some underlying chronic kidney disease.
So acute on chronic renal failure.
Exactly. But that dramatic creatinine increase and the oliguria tell us there's an acute component at play as well.
So we've ruled out obstruction thanks to the ultrasound.
Right, which leaves us with pre-renal failure potentially progressing to acute tubular necrosis, or ATN for short.
ATN, that's a scary thought.
It's unfortunately a common complication in these situations, especially with all of Mr. Griffith's risk factors.
Like his dehydration and hypotension.
Exactly.
But for those who might need a refresher, what exactly is happening in ATN at the cellular level?
So imagine the tubular cells in the kidneys as these tiny little factories working hard to filter out waste products. But in ATN, these factories get damaged, they can't function properly, and they start shutting down.
Oh, no.
And to make matters worse, all the cellular debris starts piling up, creating a blockage.
So it's like a traffic jam in the kidneys.
Exactly. And that explains why we see oliguria and why the creatinine starts climbing so rapidly.
The kidneys are basically saying we can't handle this anymore.
Pretty much.
So we're leaning towards acute on chronic renal failure with a strong suspicion of ATN. What's the plan of attack?
Well, the first priority is to restore his intravascular volume. We need to flood the system with IV fluids.
Okay, so good old normal saline.
Exactly. No need for fancy colloids in this case.
But we have to be careful, right? Because of his history of pulmonary edema.
Absolutely. We don't want to overload him. It's a delicate balancing act.
So it's like fluid management Jenga.
Huh. I like that analogy.
What else is on the to-do list?
We need to stop any medications that could be harming his kidneys. So in this case, that means discontinuing his lisinopril.
Makes sense. And what about his metformin?
With this level of kidney dysfunction, metformin is a no-go because of the risk of lactic acidosis.
Right. So we'll need to find another way to manage his blood sugar.
Exactly. And of course, we can't forget about that pesky diarrhea.
We need to figure out what's causing it and treat it aggressively.
I agree. Given the clinical picture, empirical treatment for C. difficile infection is a good idea even before the stool culture comes back.
So metronidazole it is.
You got it.
And we should probably think about gastric protection as well, right?
Absolutely. Patients with acute renal failure are at higher risk for GI bleeding.
Okay, so now I remember back in my nephrology rotations, we used to talk a lot about urine sodium.
Yeah.
Is that still relevant for distinguishing pre-renal failure from ATN?
Well, in theory, yes.
Yeah.
In ATN, the damaged tubular cells can't reabsorb sodium properly, so you'd expect to see high levels in the urine.
Makes sense.
But in real life, we rarely wait for those urine sodium results before making a decision.
Because the clinical picture usually gives us enough information.
Exactly. By the time those lab results come back, we've usually already started treatment based on how the patient is responding.
That's a good point. So you gave Mr. Griffiths his initial fluid bolus, but even after 2.5 liters over 6 hours, his urine output was still stubbornly low.
And on top of that, he started showing signs of fluid overload, prominent JBP, and some crackles in his lungs.
So what did you do next? This is where things get really interesting.
We were in a bit of a tough spot there. Oliguric and overloaded. It was a real nephrology puzzle.
It's like you're trying to solve a Rubik's Cube in the dark. So what was the next move?
Well, we decided to pull out the big guns, IV furosemide, that loop diuretic that can sometimes kickstart the kidneys.
Ah, the furosemide challenge, a classic way to tell if it's just stubborn pre-renal failure or the dreaded ATN.
Exactly. If his tubular cells were still somewhat functional, he should have responded to the fluids and the furosemide with a good increase in urine output. But if ATN had set in well, then the kidneys might just stay quiet.
So it was a gamble, but one worth taking.
Absolutely. And we had to remember that furosemide can be a bit of a double-edged sword, especially in a patient who's already dehydrated with pre-renal failure. It could actually backfire and make things worse.
Like adding fuel to the fire.
Exactly. And we couldn't forget about those ongoing GI losses. It was a constant battle to keep up with his fluid balance. Even if he responded to the diuretic, we had to be super careful about replacing those fluids to prevent another round of pre-renal issues.
Fluid management in these cases is like walking a tightrope, one wrong step and it's all over.
It really is. Frequent clinical assessments and daily weights, those are your best friends in this situation.
So tell me, did the furosemide work its magic? Did we get those kidneys flowing again?
Drum roll, please.
It did.
We gave him 150 milligrams of IV furosemide over an hour, and within 60 minutes, his urine output started to pick up, got up to 100 milliliters, and stayed above 50 milliliters per hour after that. We were all very relieved.
That's great news. The kidneys are back in business.
Well, not completely out of the woods yet, but it was a big step in the right direction.
So with the furosemide working, what was the plan for fluid replacement going forward?
We had to consider his insensible losses, which were probably higher than normal because of the diarrhea. And of course, we had to carefully replace whatever fluid he was losing in his urine.
So a very dynamic fluid management strategy, always adjusting based on his clinical status and urine output.
Exactly. Always staying one step ahead.
And I'm guessing those daily weights were still crucial.
Absolutely. Sometimes the good old-fashioned clinical assessment tools are the most valuable.
I agree. So what about that stool sample we sent off? Did it confirm our suspicions?
It sure did. It came back positive for C. difficile toxin, which wasn't a surprise at that point.
Metronidazole was already doing its job right.
Yep. His diarrhea gradually improved over the next few days, and with careful fluid management and continued metronidazole treatment, his creatinine started to come down, got down to 349 micromoles per liter by day 5.
That's a great improvement.
So a happy ending for Mr. Griffiths. Well, not exactly a fairy tale ending. While his renal function did recover, his creatinine eventually stabilized around 220 micromoles per liter, but his overall health took a bit of a hit. He became much weaker and his mobility really declined.
Oh, that's sad.
Yeah.
It's a good reminder that even when acute kidney injury resolves, it can have a lasting impact.
It's not just about the numbers. It's about the whole patient and how their quality of life is affected.
This case really shows how complex acute kidney injury can be, especially in older patients with multiple health problems.
I completely agree. And it highlights how important it is to recognize it early, treat it aggressively, and take a holistic approach to care. We need to think beyond just the creatinine levels and consider the whole person.
Well said. Now, before we wrap up this deep dive, I want to go back to something you mentioned earlier about the blood supply to the renal tubules. Why are they so vulnerable to things like low blood pressure?
It all comes down to anatomy. The way the blood supply is set up in the kidneys, the tubules kind of get the leftovers after the glomeruli have had their share.
So they're already at a disadvantage.
Exactly. And the renal medulla, where the tubules are, is naturally a bit oxygen deprived compared to the cortex. And when the blood pressure drops, it gets even worse.
Because the body tries to protect the glomerular filtration rate by constricting the efferent arteriole. It's like squeezing a hose.
Right. You increase the pressure upstream, but decrease the flow downstream. And that downstream flow is what feeds the tubules. They're caught in the middle of this physiological tug of war.
So they're the innocent bystanders.
Exactly. And that's why they're so easily damaged when there's low blood pressure or low blood volume.
That makes a lot of sense.
Yeah.
It's amazing how understanding the physiology can help us understand what's happening clinically. Yeah, it's like you dodge one problem, but then another one pops up.
Exactly. Acute kidney injury isn't just a temporary thing. It can really have a ripple effect, impacting physical function, cognitive abilities, even overall well-being.
So even when the creatinine starts to look better, the story isn't necessarily over.
Right. We need to think about what happens after that initial acute phase and the potential long-term consequences for the patient.
This case really highlights the importance of a team approach. Nurses, pharmacists, intensivists, everyone working together.
Absolutely. Got to have all hands on deck.
For sure. So before we wrap up this deep dive, I want to leave our listeners with a question to ponder Mr. Griffiths. He recovered his kidney function, but his overall health declined, and he lost a lot of independence. It makes you think about the long-term effects of acute kidney injury on a patient's quality of life.
It's a really important question and one we need to keep researching. Acute kidney injury can increase the risk of chronic kidney disease, heart problems, cognitive decline, even frailty.
It's a reminder that acute kidney injury isn't just a small setback. It can have a big impact on a person's life.
Definitely. We need to move beyond just managing the immediate problem and focus on providing comprehensive care that addresses the long-term effects as well.
Well said. And on that note, we'll wrap up this episode of Nephromapp's Clinical Cases Uncovered. We hope you enjoyed this deep dive into the world of acute kidney injury.
And remember, keep those nephrology brains sharp and those fluids flowing. We'll catch you on the next episode.